Thank you very much. Thanks to Dr. Manoria and Dr. Mahapatra for allowing me to talk on kidney part of in a diabetic conclave. Now, as a nephrologist, first we knew that we used to give a lot of importance to creatinine. But as you can see, Dr. Sabu's slide, with 1.5 creatinine, GFR was 55. So the creatinine value 1.5 can be with GFR of 20 to 90 ml, depending on various other factors. What is the age of the patient? What is the body surface area of the patient? Now, if the age is small, say 20 years, 1.5 creatinine would mean a GFR of 90 ml. But if the age is 80, then same 1.5 creatinine would mean a GFR of 30 ml. Same way, if a person is a robust muscle-built man, 1.5 creatinine can be associated with GFR of 120 ml per minute. But if it's a geriatric or a pediatric patient with a thin muscle mass, same 1.5 creatinine would indicate a GFR of 30 to 40 ml per minute. So we have realized that creatinine is not a good marker of the index of renal function. So what is accepted now, and hence probably I've been told to talk on eGFR, that is we must always ask for eGFR from all our labs wherein we ask for creatinine. Because creatinine is very ambiguous, does not give us a good indication of kidney function. So GFR now is accepted as the best overall index of kidney function. Now, not only glomerular filtration, but it also is an index of tubular reabsorption, secretion of endocrine, that is erythropoietin synthesis, and electrolyte metabolic control. Overall index of kidney function depends on GFR. Probably it is same like hemoglobin A1C for a diabetologist. Now, the second point that I want to make is this GFR is sum of filtration rates of all functioning nephrons. Now, it's a rough measure of number of functioning nephrons. Another problem with GFR is the level of GFR does not reflect the loss of nephrons. And I'm going to talk on this in a diabetic scenario in my subsequent slide. So the substantial kidney damage must happen before GFR declines. So the normal glomerular filtration rate is 180 liters per day, that is 125 ml per minute. And the normal value is a big built person with a large kidney, GFR will be more, and a small built person with a small kidney, GFR will be low. Hence, we need to correct this GFR with body surface area. So multiply it by 1.73 meters square, which is a normal body surface area of a healthy adult male or female. There are considerable variations even among normal individuals, as I said earlier, various other factors, and GFR decreases with age. This should be remembered. Now, we all know that we have classified kidney disease depending on GFR. Above 60 ml per minute up to 120 ml per minute is normal GFR. 15 to 60 ml per minute is labeled as chronic kidney disease. And below 15 ml per minute is considered kidney failure. Now, this was an excellent heat diagram or color diagram of initially we staged kidney function only on the basis of GFR. And then we realized that albuminuria is as important or maybe more important than GFR, because albuminuria may be present even with normal GFR. So maybe the first indicator of renal dysfunction may be albuminuria. So, and I'm going to discuss this further on how we're going to assess albuminuria and what is urine albumin creatinine ratio. But to see this color diagram, the green indicates low renal risk, yellow moderate renal risk, orange high renal risk, and red very high renal risk. So whenever we nephrologists are called in to give fitness from nephrology point of view for say cardiac procedure or for any amputation or other things, we rely on this diagram to decide on whether the risk is mild, moderate, or severe, or very severe. Now, this is a very interesting slide. This shows that the GFR in a healthy aging person beyond say 70 years, the GFR touches around 60 ml per minute. and beyond 70, the GFR goes below 60 ml per minute. But these are normal, healthy, aged people. So the biggest problem for the earlier, my diagram of staging of CKD, wherein we have said that below 60 ml is considered as CKD. So all those elderly people above 70 years old are not CKD patients. Now, probably we may try to modify this staging classification issued by KDIGO earlier. So in patients with kidney disease, reduction of GFR implies progression of underlying disease. And the level of GFR is important for diagnostic, for prognostic, and for the treatment modality of kidney disorder. Now, the point which I was making, that level of GFR does not reflect loss of nephrons. And this is what my third point makes it very clear, that as the nephrons get damaged, the remaining nephrons undergo compensatory hypertrophy and hyperfiltration. This is very classically seen in diabetic scenario. So supposing you're instead of 1 million nephron per kidney, you lose 50% of the nephrons, the GFR should drop down to 50 ml per minute. It doesn't happen that, because the individual nephron undergoes hypertrophy and hyperfiltration and compensates for the loss of nephron mass loss. So this is counterproductive up to a certain extent, beyond which this is counterproductive. And hence we are giving various nephroprotective drugs like RAS blockers, now SGLT2 blockers, and then of course mineralocorticoid receptor antagonists for renal preservation, because we want to prevent this compensatory hypertrophy and hyperfiltration, falsely maintaining the GFR at a same level. Now, GFR can be assessed by two methods, the measurement and by estimated GFR. The measured GFR is a cumbersome process, it's a complex, time-consuming, and we only resort to measured GFR when we are dealing with certain specific scenarios, like when you are assessing a donor for kidney transplantation, or we are detecting in the process of detection of kidney failure in the earlier stages, or you are in the calculating the dose of chemotherapy or antibiotic therapy, or when you have obstructive nephropathy, we want to evaluate the kidney function, single individual kidney function, to decide whether to remove that kidney or to preserve that kidney. So this measured GFR is not a gold, but a gold-plated standard. And this is resorted to by us in a very exceptional circumstances, like as I mentioned earlier. And how do we measure GFR? We make use of certain external molecules and certain endogenous molecules. The endogenous one which we resort as so far is creatinine only. The exogenous ones are various radionucleotide labeled molecules. The first one, which was historical, was inulin, which I will talk subsequently. Then we have technetium-99, DTPA. This is done in India and in United States most of the time. And chromium level EDTA, this is mainly in the European countries. Now this, and then of course we have iconical iohexol, iothalamate. These all molecules are filtered by the glomerulus, and either they are reabsorbed or they are secreted by the tubules, nor are they metabolized by the kidney. So this inulin, Homer Smith was the first to come across this inulin clearance, but it is very cumbersome. It requires continuous infusion of insulin and bladder catheterization and continuous measurement of the urine. So ultimately, we have come to a conclusion that GFR measurement is very cumbersome and impractical. So we rely on what is called as a clearance. We do creatinine clearance or inulin clearance, that is UV upon P. This is very classically, we knew this in our physiology days, first MBBS, that urine volume concentration into urine volume divided by plasma concentration divided by 1440, that will give you ml per minute of GFR. So all these radioactive molecules, DTPA, EDTA, they all are used to measure GFR. But as I am taught to talk on eGFR, which is the estimated GFR, what is the routine methodology of finding out GFR? The least cumbersome, easiest indicator of index of renal function is estimation of eGFR. From the creatinine value and from other age, sex, and weight, we can calculate eGFR by certain formulas. The commonest formula which we used to make use of them was Cockcroft and Gold formula. Then we have this MDRD, and then now latest we have CKD epidemiology formula. So the accurate estimation of index of renal function is by GFR and not by creatinine. The only problem with this is in acute kidney injury, this GFR is not reliable. So then we have this Cockcroft and Gold, and this is very known to all of us, 140 minus age into lean body weight divided by creatinine into 72. Now this lean body weight is again issue with Cockcroft and Gold. If you have a person who is fat and is obese or is edematous, it will give us a wrong reading of creatinine clearance from Cockcroft and Gold formula. So we try to normalize with the body surface area, both Cockcroft and Gold and MDRD, that is modification of dietary renal disease. And then we now have CKD AP formula, that is epidemiological cohort collaboration. So lastly, again talking about MDRD and Cockcroft and Gold are good when the GFR is less than 60 ml per minute. But they are not so reliable when the GFR is more than 60 ml per minute. When it is more than 60 ml per minute, the reliable formula is CKD AP formula. And all these are very easy to calculate from our palm top or our laptop. You just have to feed the value of creatinine.
1 limit left, sir.
Okay. Now I'll talk about, finally, CKD AP gives you the best depending on the creatinine and what is called as cystatin C. So cystatin C creatinine corrected CKD AP is the best indicator of estimated GFR. Now, as I said earlier, albuminuria, proteinuria is again maybe the first factor to happen before even GFR goes down. So we lose about 150 milligram of protein per day, but use albumin loss is less than 10 milligram per day. So the district method that we use is a very crude method. Only if protein increases more than 500 milligram, it is detected, or albumin more than 300 milligram are detected. And now for your diabetic kidney disease, we must measure albuminuria, and we have a micral radioimmunoassay method, not a district method, to measure the smaller amount of albumin which is excreted. Now we just want to tell you that this less than 30 ml is low. 30 to 300, which used to be called macroalbuminuria earlier, no more called macroalbuminuria, is a moderate, and more than 300 milligram per gram or per day is a severe proteinuria. So 24 hours, gone are the days wherein we use for 24 hours urine collection because it's very cumbersome, messy. It can undergo over or underestimation. But if you do a spot urine sample, preferably the first urine sample of albumin creatinine ratio. Why albumin creatinine? Because to reduce the confounding factor of hydration or diuresis, because both will go in the same direction, albumin and creatinine. So hence we measure albumin creatinine ratio. This is an excellent surrogate endpoint for cardiovascular disease because albuminuria is a great indicator of endothelial or vascular damage. So from albuminuria, you can get a prognostic indication of the renal damage and also of the cardiovascular outcome of the patient. So the KDIGO finally has said that when you are assessing diabetic kidney disease or glomerular kidney disease, you must look for urine albumin creatinine ratio. But when you are looking for tubular congenital renal disorder, especially in children, or overflow proteinuria, then protein creatinine ratio is good enough. And lastly, I must say that urine protein creatinine ratio is less cumbersome to do it. It is very practical to do, and that remains a rational alternative today because the prognostic value is recently determined to be equivalent to urine albumin creatinine ratio. So friends, urine protein creatinine ratio or albumin creatinine ratio on a spot urine sample, preferably first morning sample, is excellent marker. We don't have to do 24 hours urinary protein excretion measures, and proteinuria is as important as the level of GFR, which is estimated by routine methodology as called by estimated GFR by various formulas which I have said. Now, lastly, the protein creatinine and albumin creatinine ratio, as I said earlier, are both excellent predictive risk factors for all-cause mortality, especially cardiovascular disease or atherosclerotic cardiovascular disease. Thank you very much for your kind listening.